the hospital
This meeting is being recorded.
And also from their own personal locations. So welcome. The resources that you have available here in Chattanooga are also something that I wanted to remind you of. It's on our website. However, everybody should be aware of the LifeBridge program. If you are not, the number is 591-9830. So it's a 423 area code with the number 591-9830. This is really a valuable resource. I do know that we had a great resource in Miss Jessie Kelly. I will tell you that we are committed. We've got another job description and job posting approved, which should be ready to be disseminated, and we should be recruiting. I really appreciate Dean Haynes making that a priority. With that, I'm going to introduce our speaker today, and I am doing this the wrong way. Sorry, Dr. McLerran. Dr. Samantha McLerran is dually boarded. She is a family medicine physician and also an emergency physician. She's clinically active. And she also is representing the Tennessee Board of Medical Examiners today. One of the issues that we have been working around nationally is to destigmatize or normalize the issues around mental and behavioral problems. We all know that we have to get a physical fitness for duty before we start work, but we are hesitant due to licensing, credentialing, and other implications to disclose or even seek help when we feel that we are dealing with the stresses that we encounter each day. And being in healthcare, our life is definitely, each day sprinkled with moments of joy, but we see patients at their worst. They come to us when they are extremely vulnerable and suffering, and that really impacts who we are. However, we are supposed to show up as superheroes and not feel those emotions, or not at least externalize those. And that has long-standing implications. So the Tennessee Medical Association, with our own representative through the Medical Society, have been working very diligently with the Tennessee Board of Medical Examiners and the Federation Medical State Boards to really remove any such language in the licensing documents. And that has been quite successful, including in Tennessee. However, we are still working on what that means for local hospital credentialing documents. To help us more with that, I think I really want to thank Dr. McLerran for her leadership in the Tennessee Board of Medical Examiners. I'm not going to steal her thunder. She's got a great bio that she's going to disclose, and you can already get some idea looking at the pictures up here. So with that, Dr. McLerran, whenever you're ready, I can advance your slides for you. And thank you again for being here.
Okay. Welcome. First of all, I want to apologize for not being able to be there in person. As you can see, I come from a large family. I'm not only a full-time physician, but a working mom of 3 children, one of whom I'm going to have to unexpectedly do some mom things with, deal with a medical thing. We also are a working full-time Angus beef farm. My husband's family has had the land that we live on for 6 generations. So that keeps me busy and grounded in a different world. One thing I would recommend when you're dealing with stress from being a physician is find something that keeps you grounded, whatever that is. And although some days my husband is a different kind of stress. I trained in undergrad at Tennessee Tech. I trained in medical school at Meharry, and I am eternally grateful for that. They granted me medical training when a lot of the state schools were like, you're a little young, come back in a little bit. I did my residency through the University of Louisville in Glasgow Family Medicine. And then I did get a fellow in family medicine in 2009, and I got my emergency medicine boards after I had returned to my first love, which was emergency medicine, through the American Board of Physician Specialties in 2018. I've worked now in emergency medicine for 13 years, give or take if I'm doing my math right. And it is tremendously stressful working through the pandemic. I was appointed to the board of medicine. So I hate it when presenters say and I'm doing it a lot. I believe it's 2 years now by Governor Bill Lee. And that has been a tremendously enlightening experience. If you would advance the slide, I think I speak to that next. Before I was on the Board of Medicine, I had a very frightening experience of what the Board of Medicine did. Board of Medical Examiners, I thought they were the people that were very scary and came and took your license away. We actually do a tremendous amount, and I'm pleased to say that we are not the men in black. We do not do terrible things. We've worked very diligently. We are a group of physicians and consumer members that have worked to, one of the things I'm proud of in the last 2 years that we've done is work to rewrite the actual questions that are on your renewal application. I just actually did mine 2 weeks ago, a week ago. So I got to experience those questions firsthand. They're not perfect. Everything is a work in progress, and we'll go through some of those later on in the presentation. As with the Federation of State Medical Boards, destigmatization of mental illness in this country, dealing with burnout and stressors needs to become a priority. Your health is a priority. None of us can care for patients if we are not caring for ourselves. And I can't see that because that's a tiny little picture. It's rotating through all the people that are signing in. So I have a tiny little picture I'm trying to read right now. This is entertaining. Let's see if I can.
So, Dr. McLerran, we have Ms. Scott managing the chat. So I don't, if you want to just ignore the chat, that would be fine. We can monitor it from here. It's
not the chat, Dr. Panda. It was rotating through everyone signing in and giving me the tiny little view. Currently on the Tennessee Board of Medical Examiners, we have an orthopedist, a cardiologist, a pediatrician, Debbie from Knoxville. There's myself. Dr. Melanie Blake is our president. She's there from Chattanooga. I'm going to leave out somebody. Dr. Stephen Lloyd represents mental health and addictive medicine very well. We just got new consumer members. There's a gentleman from south of Nashville. Archie Ellis is from Knoxville. I'm going to be in trouble. For Miss Phyllis, Dr. Phyllis just retired from Chattanooga. We have several new members that have just turned over. We meet every other month. All of our meetings are sunshined. If any of you ever want to watch them, you can log on. Everything we do is available for sunshine. The first day we hear applicants whose license have been deemed that need further review by the board, and the second day is the hearings. The other thing I've learned from being on the board is you don't have to be afraid of attorneys. They're not all bad. It's just interpretations of the law. If you go to the next slide. Oh, this is tiny. The Board of Medical Examiners was created in 1901 by an act of the legislature. Our mission, and you'll hear this said over and over in our meetings, is to protect the health, safety, and welfare of the people of Tennessee. A lot of times, if you get asked to come before us, that doesn't necessarily mean that there is something negative in your application. We've had several applicants recently who have come before us with the support of the Tennessee Medical Foundation, which we'll talk about in a minute, that did not have any, we just needed to talk to them, and they, several of them got full and unrestricted licenses despite having have dealt with behavioral or mental health issues in their past. It doesn't necessarily mean that you will not be granted a license. The board's mandate is to interpret the laws, rules, and regulations to determine the appropriate standards of practice. And we have a whole administrative staff and work with the Office of Inspector General to investigate cases. If you go to the next slide, that's a lot of writing.
Yes, and Dr. McLerran, if you want to go to the full screen mode on your laptop, that will help you just see the screen. I just checked with our AV guru here.
Oh, okay.
All right, I hope that helps.
Oh, there we go. Yes. Okay.
Great, thank you.
And so now we'll talk about some things that I have enjoyed. These are some things you need to watch for. Being an altruistic doctor, this is what we all train to be. So the next click, a perfectionist. Next, you can click through these. A workaholic tendency, being a lone ranger, being where the patient comes first. That might mean that you don't take care of yourself or your family obligations. Also, a lot of us, especially in my age group and older, have trained to never show weakness and willingness to delay our own personal gratification for our career goals. I'm going to take a minute to speak to this because this last week in my own life has demonstrated how important it is to take time for personal healing. I watched very difficult cases and I've had to take a moment for personal reflection because I trained to do this and I've watched how important it is to take a moment to reflect. You're all training to do this. And if you don't take those moments, you're going to end up with burnout or even worse, destructive tendencies, addictive behaviors. There is nothing more important than caring for yourself. And that is what we want to stress, not only as a member of the Board of Medicine, but as a colleague, as a mom, as a doctor. I lost 2 very difficult cases in the ER this week. I will carry them with me for a while. There is no going back from that loss. It wasn't anything that could have been changed. It's just something you carry with you whenever you start facing those losses. If you'll go to the next slide. But when I started training, I felt it wasn't okay to express that I had a really bad week. I need a minute. I've got to face this. When I started working with Dr. Barron, who runs the Tennessee Medical Foundation, he used to be a member of the board to help me with this presentation. I did not realize that 80% of physicians have obsessive compulsive personality traits, which is good for us in our work. It's good to care about our work and to make sure we don't miss things, but it feeds doubt that we miss things, guilt that we're not getting it done right, and we have an exaggerated sense of responsibility to get everything overworked. And if not cared for, these can lead to negative behavioral outcomes. Next. I really found this quote and I liked it. It's from JAMA, that herein lies the grand paradox. Compulsiveness and excessive conscientiousness are character traits that are socially valuable, but personally expensive. Society's meat is the physician's poison. We are training you from an early age in high school that you have to do and be and do the best and achieve, regardless of taking time for mental wellness and health. And that's not the answer. You want to take that time so that you don't develop bad habits. Next. So when would you get a referral to the Tennessee Medical Foundation? Next. And then I guess my next question would be, does anyone know what the Tennessee Medical Foundation is. This would be so much easier if I was there with y'all. I'm very interactive. Okay, next. You can click. The Tennessee Medical Foundation is the physician health program in the state of Tennessee. The main reasons physicians in our state get sent, and hopefully they go voluntarily before they get referred to the board, or by their hospital and risk losing their privileges and have a reportable event, is boundary violations, disruptive behavior, addiction and substance use disorder, and burnout syndrome. Some things you want to clarify: impairment versus illness. Flu is an illness. Alcohol use is okay if you're having a glass of wine with dinner and it does not affect your patient care. Alcohol use disorder is not okay because that affects your patient care and your ability to be a functioning physician. A disruptive physician. A lot of times these are doctors that see themselves as very competent providing physicians. They're often very well liked by their patients. They see themselves as very superior. They see other people as incompetent, and they're very smart. They see themselves as the champions. However, these often lead to errors, delays in care. That's a real problem. And this can lead to reported behaviors and need to report to the Tennessee Medical, not only to the medical board, but to the Tennessee Medical Foundation. These behaviors are used to intimidate, control, and blame. It does not lead to good communication between yourself and your staff if your staff feels intimidated by you. I work in a busy ER. We see about 130 to 150 patients a day. And I can guarantee you when one of my mid-levels is going to come and say, why don't you call this attending? We all know who that attending is. Nobody wants to call them. And that's wrong in medicine. We shouldn't function that way in 2022, we're going to 23. Sorry, 3 kids. Next slide. Disruptive physicians and behavior lead to over 50% of errors because of communication breakdown. I found these as interesting stats. 30% of OBGYN errors due to communication mishaps, according to obstetric gynecology, and 91% of adverse events involving residents due to communication failures. And that was from Healthcare 2004. I don't know if those stats are better now, but I do remember being a resident and going, no, I'm not calling them. It's 2 o'clock in the morning and I'm not calling. And that is unacceptable. If you'll go to the next slide. Boundary violations, professional sexual misconduct. It is never appropriate for you as a physician to engage in sexual behavior, whether it's initiated by you or initiated by the patient, because you're in a position of power. And that is included and not limited to sexual intercourse, masturbation, genital contact in any way. If you go to the next slide. It's harmful to the patient. It loses objective care, and it's always on the physician in these relationships, and it can never be consensual. And these violations can end your career in a point of being reported not only to the medical board, but to your hospital with loss of privileges. It can be a very slippery slope. To the next slide. There's my slippery slope. Boundary violations, it feels, from the cases that I've seen brought before us, a lot of times it feels like, from the conversations that I've had, that these physicians feel like they're facing oblivion. They're not. There are classes, there are programs, there are physician health programs that they can get into. So there is a way out. There is education and there are plans. So you do not have to feel that this pattern of self-destructive behavior is going to cost you everything, but it is a very slippery slope from a first mistake to potentially long-term career consequences. You need to know the rules, and there are well-published rules on physician-patient sexual relations. They're published in the AMA, APA, the Federation of State Medical Boards. You need to know your weaknesses. You should have supervision. You should watch for red flags, such as text that go from questions about lab results to flirtiness, emails that can breach the same way. Physicians today practice in a world of electronic communication that was not there when I graduated 24 years ago, 22 years ago. Always use a practice monitor and a chaperone, and know what to do if a patient or yourself begins to cross the line. Know who to go report to, either in your practice, in your hospital, if you're in a solo group, know who to contact at the TMA, know who and where to go to seek help. Always, you can self-report to the Tennessee Medical Foundation. They have a website, there's contact information out there and available. And it is far better to self-report and seek help than to get reported and be required to seek help. All right, next slide. This is a very famous picture. It is the scream. I think this is what a lot of physicians have felt like, especially working through the pandemic over the last few years. It's also one of my favorite pieces of art, but it really represents how a lot of us feel some days. If you'll go to the next one. Physician burnout. It's emotional exhaustion. It's detachment. It's a feeling like you're not achieving anything. And working in emergency medicine, I would be lying if I said I didn't feel this way some days. You feel depleted, frustrated, that the system is failing, that it doesn't matter what you do, you are losing empathy with your patients and with others. You see your patients as a diagnosis, not as people. And it's very hard to remember that these are people that are frustrated and scared, and they're coming to you for help. And it is a gift to be able to provide care for people that are scared and frustrated, because they're burnt out too. A lot of human beings are. If you'll go to the next slide. This is a quote on why physicians die by suicide: the erosion of soul, a lack of direction, and the inability to take charge of one's work or life. Next. And these are just some pictures that really spoke to me. I have seen colleagues. I have felt this myself. I certainly have felt this. Every day that you go into medicine, you are given a gift. You have been given the gift of healing, whether that is dermatology, radiology, OBGYN, emergency medicine, pediatrics. You are given the gift to walk in and allay people's fears. And it is an amazing gift. And what we want to ensure is that you're allowed to protect your own soul and your own mental health while you're doing it. If you'll go to the next slide. And we don't want you to feel this triad of exhaustion, burnout, and detachment. Next. So the symptoms of burnout are going to be over here on, I don't know if that'll be the right-hand side of your slides. But it's exhaustion, insomnia, withdrawal. You can start having boundary violations. You can become that disruptive physician, that one that you never really wanted to work with. You can start using substance abuse. Physicians' number one substance abuse is alcohol. You can get depressed. You can even, physicians have suicide. Next. And there's burnout versus stressed out. The burnout physician is disengaged. Their emotions are blunted. They have no urgency. They have no energy. They have an increased risk of suicide. Stressed out, they're over-engaged. Their emotions are overactive. They do have a sense of urgency. They have that emotional energy. This might be the doctor that snaps at you. And they're often sometimes sick. So keep this slide in mind and try not to be, you really don't want to be either one. But keeping our own health in mind is very important. Next. Comparing physicians to the general population, we are more likely to be burnt out by, general population is 24%, we're 48.8%. That's a scary statistic to me. Again, both as a colleague and as a member of the Tennessee Medical Board. Next. I think the end of this quote, that burnout is the sum total of hundreds of thousands of tiny betrayals of purpose, each one so minute that it hardly attracts notice. And that's from the Atlantic, February 2014. For me, this is where I don't have a bed to put somebody, where I have EMS patients lined up down the hallway. I didn't get to eat my lunch this shift. You've had the feeling. It's a difficult day. But I also have colleagues that make my day very worthwhile. And I come home to a great family, and we're right now having calving season. So there's a lot of great things in life. If you'll go to the next slide. I wonder if those are as tiny for you as they are for me. This is physicians in 2014 and 2011. So the yellow is 2011 reporting burnout in different specialties versus 2014. And you can see, you don't have to have a graph for this. You talk to your colleagues. You can see the numbers of how much burnout has increased across medicine, across our specialties. When I did this talk, I went, oh, great, look where I am. And if you look at the next one, these are just different years. This is closer to our pandemic. And again, it's the same thing. All specialties, it doesn't matter what specialty you're in medicine, you are facing a higher rate of burnout and stress. Next. This is if you're a visual learner, here's your visual slide. This is everything I said a minute ago. Personal, professional, these are the consequences of burnout: broken relationships, alcohol, depression, decreased productivity, decreased patient satisfaction. So if you want it typed or in a little picture for you. Next. So you can treat this just like you can treat substance use disorder, just like you can treat boundary violations. You just have to recognize it and you have to get help. And that is with mindfulness training, psychotherapy. You may need depression treatment. The big thing is, as a physician, we as a group are afraid to ask traditionally. I'm glad to see with the flyer that Dr. Panda presented and with the changes we're making in our questions for licensure, that it is becoming less stigmatized. Physicians should not be afraid to say, I have an illness, because depression is an illness like high blood pressure, and I need help. So if you'll go to the next slide. This really, I like this picture because it's going to lead into the next topic. So if you'll go to the next slide. Physician suicide. It is an elephant in the room. There are about 300 to 400 physician suicide a year nationwide, with 25 resident suicide per year. And that is 20 to 40 suicides per 100,000 physician population. Female physicians are at 130% higher rate of suicide greater than your average female population. That means if you're a female doctor and you decide to kill yourself, you have a 130% chance higher rate of doing that than your average woman. If you're a male physician, you have a 40% higher rate than the average male population. However, male and female doctors' suicide rates are equal, about. So male and female doctors kill themselves at the same rate, but female physicians are much higher to do it than the average female in the general population. The story of Dr. Lorna Breen is an emergency room physician, really speaks to me. This is tiny. She worked at the New York Presbyterian Hospital in Manhattan. She actually went and got treatment. She had worked in COVID. She was very stressed from her time in emergency departments. She died by suicide on April 26th, 2020. In a period of 3 weeks, she treated COVID-19 patients, contracted COVID, and returned to overwhelming, relentless numbers of sick patients. She left work, went home to Virginia, was treated at an outpatient facility, and then killed herself. Stigmata is what killed her. If you'll go to the next slide. So there has been a Dr. Lorna Breen Healthcare Provider Protection Act. It was signed by oh goodness. Maybe I need more coffee. President Biden on 3/18/2022. It establishes grant programs and otherwise requires the Department of Health and Human Services to take actions to improve mental health and behavioral health and prevent burnout among healthcare providers. They must study issues related to and develop policy recommendations on preventing burnout and implementing mental and behavioral health among healthcare providers and removing barriers to accessing treatment and identifying strategies to promote resilience. So her tragedy and devastating loss will help move mental health and behavioral health policies forward for all of us. And it is a tragedy. If you will move the next slide forward. It is sad that we work in a field where I have to say that suicide is an occupational hazard and that increased suicide ideation begins in medical school. The other thing I have to say is that one of the biggest triggers for suicidal ideation is having a regulatory complaint filed against you, because it is devastating to have your license placed at risk when you have worked so hard for your license. If you'll go to the next slide. So our last topic is addiction. I think most everyone will know Dr. House. So we'll go on to the next slide. There are many risk factors for a physician to be at risk for addiction, and there are similar risk factors to any human to be at risk. Your genetics, a wounded family of origin, which is a high ACE score, and I put the ACE scores over here to the right. Easy access to medicine, PTSD symptomology, we turn off our emotions to function, we don't ask for help very well, prescribing to self and for family, self-medicating, all of those lead to increased risk for addiction. If you'll go to the next slide. I don't know why that didn't show the words. But these are all also risk factors for addiction. I would propose that we should put healthcare worker on there, because I looked for one and it does not show anywhere healthcare worker. But after, especially having worked through a pandemic, I feel that healthcare worker deserves to be on this slide for risk for PTSD, addiction. If you'll go to the next slide. Physicians, as I said earlier, primary substance of addiction is alcohol, then opiates, stimulants, benzos. Often physicians have dealt with an addiction for 2 years before they are found out, called out, brought to either their partners, their hospital, and Lord forbid, a law enforcement agency. They often have financial and legal issues such as a DUI. Their work performance is not typically impaired until the more advanced stages. Again, illness to impairment. And then the 43% of opiate using doctors have been using opiates for more than 2 years before detection. If you'll go to the next slide. Same barriers as with boundary violations and the other things we've talked about, that asking for help is weakness, such as eating, drinking, and sleeping, limited to no time, loss of hospital privileges, employment, licensure problems. If you'll go to the next one. There we go. Next. A lot of, and this is not every physician, but a lot of physicians feel like they have guilt when they ask for help. They're programmed to cope alone. They may have a survival mentality that things will get better if I finish residency. Things will get better when my wife's not pregnant. Things will get better next year. Or I'm the doctor, I have to just be strong for everybody else. We'll go to the next one. And that is why in this state, I'm very tickled to note that we have the Tennessee Medical Foundation, whose current director is Dr. Michael Barron. We'll go to the next one. And Dr. Barron has worked with us in getting several of the questions changed on our licensure, particularly this question: have you engaged in the excessive use of alcohol, controlled substances, prescription drugs, or in the illegal use of drugs, or received any therapy or treatment for alcohol or drug use? If you are an anonymous participant in the Tennessee Medical Foundation Physicians Health Program and are in compliance with your contract, you may answer no to this question. And you can go to the next one. We did change several other questions, which is in work to be in compliance with the Federation of State Medical Boards general push towards decreasing stigmata. And every case that comes before us gives us a chance to discuss and set new goals, and not every case changes them, but we do have very what's the word I'm looking for? Open discussions on every case that involves a participant in a behavioral issue before us. If you'll go to the next one. These are the actual questions. The question in black is the original question, and the red is the rewrite. So they're not, in some cases, they're not significantly different, but we did try to make a difference. I'll just let you look over them. For example, the first question we changed, it says now the cognitive capacity to make appropriate clinical diagnoses and treatment decisions, exercise reasonable medical judgment, and keep abreast of medical education. It's a minor word change, but it is less interrogative and less harsh. If you'll go to the next slide. And then, do you currently have any condition that is causing impairment in your ability to practice with reasonable skill and safety in an ethical and professional manner? I can't. You may answer no if you are being appropriately treated and are not impaired, which is significantly less harsh and invasive than the original question. This second question is very similarly changed. You can go to the next slide. I included these so that you can read them at your leisure. During the past 2 years, did you engage in any activity involving substance, either alcohol or controlled substance? That's the one that was in the original slide. And then the next one is, are you currently participating in a Physicians Health program or similar type program monitoring and advocacy for your physical, mental health, or substance use disorder, which has caused you impairment? So you can go to the next one. Have you ever been diagnosed or treated for paraphilia, which is just simply changing to a more modern term for pedophilia? Again, minor changes of words, but trying to be more in line with the Federation of State Medical Boards. Next one. The physician health programs. Next. A confidential resources for physicians, trainees, medical students. They facilitate early detection. They can be totally voluntary, and they often have a set monitoring for an amount of time. You can be for 2 years. The longest I have seen is lifetime, but those are for very specific issues. Next. In the state of Tennessee, we have 225 health professionals under a monitoring contract, and then they're for substance use, behavioral, sexual boundary, burnout, and you can see the breakdown there in the slide. And we have helped over 2,600 professionals work through their issues and maintain their license. Next. It is confidential. Next. So they're more likely to come forward and seek treatment. There is a screening tool now that has been developed, which is the Tennessee PSQ. This is a screening tool that any professional can go to. It has questions and it will help you identify your current risk level. If necessary, they can connect you with a counselor. They will follow up. You can give them anonymous information. I have actually taken the screening myself, and it told me that I was stressed, which I agree with. If you need help contacting a counselor, they can help you with that. If you want to maintain totally anonymous, you can do it that way as well. If you'll go to the next slide. Some end thoughts for this is not necessarily to stress that who is good or bad. The Board of Medicine, Tennessee Board of Medicine has a very difficult job. Yes, at times we have to take a licensee's medical license away, but that is not our ultimate goal. We prefer to have people with boundary violations, substance use disorder become involved in a physician's health program because all of our licensees in the state have worked very hard to get that license, and we respect that. At least that is my goal as a member of the board. I don't want to speak for the entire board. And the other thing I would say as a colleague is that as a physician, your mental health is a priority. No one should suffer abuse of any kind, whether it's verbal, physical, mental, and a physician shouldn't have to suffer that either. Overwork and martyrdom is not healthy. So, next slide. These are just some in thoughts. Again, I grew up in medicine. I was 20 when I started this, which looking back on it is very much too young. At 43, I faced a pandemic, and it is not easy, but being on the board has provided me an insight. It's okay to ask for help, and I would encourage you to know your resources, know who to ask for help, because you cannot help your patients if you cannot help yourself. Please take the questionnaire, the Tennessee PS, I'm getting my initials wrong, TNPSQ. It is a great resource. If you don't get anything else out of this talk, as medical students and residents, go on there, create an account, monitor yourself, follow along where you're at. It is free, and it is an amazing ability to sort of just do a wellness check on yourself. All right, next slide. And if you have any questions, I will be happy to answer them to the best of my ability.
Thank you, Dr. McLerran. Appreciate your being sort of working with us. I know you had last minute some technical difficulties, so appreciate that. Any questions from the audience? And Pam, you can let us know if there's anything in the chat, please. So while, just to get started, I had a question. So first, I appreciate your work on the medical board. I know that it's been long overdue, perhaps, in our state to make those changes, because the Federation for State Medical Boards had the change made a few years ago. How is the Tennessee Board of Medical Examiners going to monitor the impact of these changes? And there's a two-part question. And the second thing is, how do we monitor for similar changes in the credentialing of various hospitals in Tennessee?
So as far as hospitals, that is an individual choice. I know that I reached out to the president, Dr. Camparelli of the TMA, and these things are being encouraged. There have been discussions with the Tennessee Hospital Association, but as far as individual hospitals, that is per their own discretion. And we would have to discuss with our staff as far as monitoring processes. I didn't get to speak with them about that, so I don't have an answer for the first part of your question.
Thank you. No, we would be really, it'll be helpful to see how much difference this has made as we move forward. And I will let you know that the Medical Society, through the Medical Society, we're really working hard with our local hospitals and with our medical staff, but also with Dr. Caparelli, the president of the TMA, to sort of, like you said, help really push this for individual hospitals also. We have a question in the chat. First, thanking you for your talk. So I echo that. How do you deal with disruptive physicians?
Is that how do I deal with it personally in the emergency room or when we're at board meetings?
I would say both, perhaps.
Okay. in the emergency room, over 20 years of experience, both as a private practitioner and then in the emergency room, I have learned that it is very seldom a good idea to engage in conversation when someone is being disruptive or bullying. There is a phrase that I have taught people that work with me and residents when I've had them and med students. You don't wrestle with a pig because you both get dirty and the pig likes it. So I have learned to, if someone's going to yell and scream and get verbal, I just let them have their way, and then I very calmly explain my point of view, and I often remind them why it is in the best interest of the patient. And if they still want to be verbal or inappropriate, unfortunately, I have the number to our chief medical officer taped at my desk.
Thank you. I think on a more general level, when it becomes a trend and there is a power hierarchy, how do we deal with that?
In regards to being a disruptive position constantly?
Yeah, so suppose, say, for example, if somebody is in a junior faculty or a student or a resident and, you know, they have those inhibitions, is there, I think, I don't know the person who asked the emotive of the person who asked the question, but I'm just expanding on what was there.
Okay, I remember those days. You have that attending that you can't talk to, deal with, and it may be compromising patient care.
Perhaps.
Okay. I would say, looking back on it now, I would find a resident or an attending that I could talk to. And in every teaching facility, you should have someone above the disruptive physician, I would hope, unless your disruptive physician is chief of staff, that you could speak with. And it's very hard to have that courage and go and speak with them. But if the way I look at things now, if this is affecting my patient or my ability to do patient care, that's what I went into medicine for. And I have learned that as long as you're speaking for the patient, never be afraid to speak for your patient. So take someone with you, take another resident and go to someone that you have seen demonstrates the same level of patient care.
Thank you. I think there was another question and I didn't catch all of it. I don't know if Ms. Scott wants to read it, but I think it was something related to lack of control on the issues with medical records. And could you read it, Pam, please? Oh, there it is. How do physicians deal with the lack of control in a world of EMR and protocols?
That's a very good question. And I wish I had an answer to that, as I, as an ER physician, face that on a regular basis. I try to do what is in every day, what is in the patient's best interest. And there is nothing more frustrating than having to answer emails on my hospital system as to why I did not give a 30 cc per kg bolus for sepsis because the patient had kidney failure or congestive heart failure, and I did not want to cause harm to my patient. You are learning to practice medicine, and you have to do what is in the patient's best interest. So protocols are not always what's in the patient's best interest. Mm-hmm. I often get into verbal disagreements with our local behavioral health system because they want me to place people under mental health holds that are not appropriate because they don't have a safety plan or they don't have someone to speak for them. And that is an illegal use of a 6404. And I have never, don't be afraid to speak up for what is best for your patient, whether that is a protocol, but do it nicely, do it professionally, and make sure you document in your chart why you're doing it. is the only advice I would ever give anybody. As long as you're doing what is in your patient's best interest, you're being a good doctor.
Thank you.
Now, as far as the EHR, I don't know. They just changed mine and I hate it.
Yeah, no, thank you very much. I think just a little bit, we do have work going on in our own institution, and these two issues have been brought up, especially the one related to the lack of control on and the stress and the additional work that EMR causes. I will tell you that we had a lot of momentum on that with Dr. Adams here. And now after things are settled a little bit with COVID and leadership in our institution with Dr. Shridharani and Dr. Cohen, who are leading that role of the CMIO, to really look at that again and how can we customize the EHR for each department so that it is more user-friendly. And then the other issue of, how do you have the courage to speak up when there is a power hierarchy, and whether that's around the patient care or something that you don't agree with, or you have a disruptive physician. I think what you're talking about is really creating psychological and emotional safety in the workplace and creating relational trust. I will tell you that that is something with the new leadership in the UT system that we are really looking to make happen, right from starting with faculty development on that to empowering each other, and really that changing the culture to where there is a common shared goal that we are here to provide the best patient care and treat each other as human beings and provide the best education for our learners. And I think once we can come along the tenets of how do we relate to each other, perhaps it will become less of a fear and more of a safe place to raise those questions. Thank you for bringing the Tennessee PSQ. I just want to also share with you, Dr. McLerran, that we already have a self-monitoring system, which is the Wellbeing Index. So please shout out to the residents. If you have not signed in and logged in, please do that. We have really customized it to Chattanooga and Hamilton County so that you can get the resources that you need. And really, it'll help you and your near and dear ones to look at simple resources that may be beneficial to you. Knowing that as an organization, we realize that burnout is a sort of just an individual symptom of a system problem. All right. It's an individual symptom of a system problem. And we get that. And we are working with the leadership of the hospital and the leadership of the university to really see what system things can make. The basic question is, what do I need to do my work and do it well? Your leadership in the resident body through the resident advisory board and the physicians through the wellbeing task force are really that bring the issues to us. So please use them. And if you don't know who your leaders are in your department, I can't pull that sheet up right now, but it's on our website. So you should be able to get that. If not, just reach out to Larissa Harika. Larissa's right there. She is the resident liaison for the community of the House Staff Association, right, Larissa? So that's what I wanted to give a shout out. With that, I have 104. So Dr. McLerran, I want to say thank you to you again and good luck with your work, but also with the other fun activities that you're doing. You said, I think it was some season that you all are. I didn't catch it.
It's calving season, baby cows.
Okay, calving season, great. All right, anything else? Let's give her a round of applause. Thank you. Thanks. Thank you all for coming in person.